all to one by one should participate, everybody should participate. He should express his views where we are straying. Research is going on, but it is at such a micro level that no clinical benefits are being revealed. If you are doing lot of work on genetics, you are doing many things, but genetically engineered medicines, until they are available in the market, mankind is not going to be helped. So, my discussion will start with whether diabetes is a chronic progressive disease or not. I need comments from everybody, including the previous speaker who declared UKPD's comment. Remember, UKPD itself is very old thing. It was finished in 1998. It was over. So that itself is very old study, and many newer concepts have come up. Now, please tell me your concepts regarding whether diabetes is a chronic progressive disease or it is a reversible, curable condition.
Well, I can start.
Let's pass you the microphone.
Microphone, please. Microphone.
Press the yellow button. Press the yellow button.
Okay. The question is, can we reverse it? This is the most important one. And can we normalize the situation?
May I interrupt you? Would you use the word cure or reverse?
Reverse.
Why?
I'll tell you why, because of my experience. First of all, I am a pediatrician, but I also treat pediatric people until the age of 84, because they come to me. That means I treat pediatric population and adult population. And I'm not talking about type 1, because this is a complete different issue. Okay?
Different issue. We are talking about type 2. Yes.
Type 2. So it very much depends. I don't know if you saw my presentation. Depends on the level of insulin that you have in the blood. If you are hyperglycemic, not very high, with very high insulin, circulating insulin, you are probably overweight. And if you reduce your overweight, you can completely normalize your condition. That means you can get completely normal glucose, you can get completely normal lipids with reduction of your weight. That means, provided you keep your weight low, you are not diabetic. But this is a condition. Once you start growing up with your weight, or you are a woman who gets pregnant and there's GDM, then the problem restarts. And that means that the pancreas is too small for our very big BMI now in the 20th century. If we are smaller, and I know it because I did a lot of work on population coming from Yemen, okay? And the average adult Yemenite who comes from Yemen 50 years ago, the average weight was 52. And the average height was 140. And they didn't have any diabetes when they came to Israel. Once they entered into the westernization culture, they developed the highest prevalence of diabetes. That means our body, by evolution, is not made for such big diet, high diet, and overweight. Once we reduce it, the internal organs would start again working very well. So it is conditioned. It's a condition that can, you can reverse it. And you can reverse it not only in the beginning, but also later in life. I mean, when you are 40 years old or 50 years old, once you get rid of some of your overweight, you can normalize your blood sugar. So it's a reversible condition.
First of all, I would like to make clear, word cure is not used because we do not have any long-term study. So the word is restricted only to reversal. And secondly, the failure rate is also equally high. Even with bariatric surgery, about 70 to 80% patients reverse to diabetic status after 6 to 8 years. So that is why the word cure is not used, number one. Number two, her concept is very clear. Since the body is large, pancreas falls short in size, right? But that is not correct, because it has been found that there are many normal diabetic, normal obese patients who do not have any diabetes. So that is, had it been so, all obese patients should be diabetic. So nothing doing with their size of the body. Then if you compare the incidence of diabetes in developing world and developed world, then also this thing becomes very clear. Usually Southeast Asian persons are shorter, smaller, still they have very high incidence of diabetes. So nothing doing with the stature as far as the modern concept and the literature goes. Your experience might be your own experience, but is not, it doesn't stand with logic. Anybody else who want to make any comment?
Yes. Please take some time.
Yes, up till now, Yannick, it was believed that this.
Microphone close to your mouth, yeah, thank you.
It was believed. It is still in many parts of the in many countries. It is still believed that this is a progressive disease, but now it is a new concept. It starts with low GI diets. After this concept, now it has been believed that by using these low GI diets, you cannot either stop the process of this, and you can reverse this condition. Reverse to, and then you can maintain at that level. Just other people's with normal people are doing like that. Another point is, after now it is believed, before it was believed that there are high risk patients, low risk patients. Due to that, if suppose people were saying that because this is in my genes, if I am obese, whatever the reason is, whatever I will take, I will develop diabetes. The other people who were low risk, they were thinking that whatever I will do, I will not develop it. But this concept is not there. Genes are not our destiny. It is said now, it's very clear.
Very correct.
So
very
genes...
correct. Family is not a must these days.
Yes.
Because more than 50% patient now, when we diagnose, there is no history of diabetes, even documented history in last 3 generations or so. Because many times I get a doctor whose father was doctor, his forefather was doctor, and they were very concerned about diabetes. They used to get it checked on time. Still they did not have diabetes. But still, this generation is getting diabetes, and of course it's a lifestyle problem.
But in our clinical practice, we see this is continuously, it is progressive.
Progressing, yes.
It is in our clinical practice. But there are individual cases reported worldwide, because from different parts of the world, that there are few cases which were totally reversed. But there are very few studies, very few cases. But with this concept of the low GI diet, if you can start and you can maintain, you can reverse it.
First of all, I would like to make a very interesting comment. When we say reversal, we don't mean control. By low GI diet, you may get your blood sugar levels within normal range, but that is not reversal. That is just a control without even medicines. Even if you achieve control without medicine, with exercise and diet, that is not reversal. Reversal means when even glucose load can be handled normally. Remember, unless one is passed through this test, you cannot use the word reversal.
After reversal, you have to control, maintain.
No. First, let us decide the point where we will use the word reversal. The word reversal should be used only when whatever you do as an exercise or as a maneuvering, but the golden criteria is that 2-hour post-glucose load should be within normal limit, then only we will use the word reversal. So this is for those who are going to make future comments. We are not intending to get good control with diet, exercise, weight reduction, etc. and aim to get rid of the pills. What we mean is a scientific reversal, means the diabetic process has been neutralized and even the post-glucose load is normal. Now, please proceed. Somebody else.
Would you like to comment about, because Dr. Shankhdhar was not here, how you and Dr. Landwa were totally paradigm shift about that you do not care about the glucose, rather you care about the insulin level. Would you please put, because you have a first-hand experience on that.
Well, what we are, few of the members that were here, and for several years, this is not a new thing, that we are saying just the paradigm of diabetes that would say glucose over this and the glucose over this is not helping us very much because the numbers are increasing, the prevalence is increasing, and the problems are increasing. And it seems to be that we are intervening too late. So, I mean, we think that effort should be invested much earlier. And glucose should not be the only criteria. And one of the most important things is the level of hyperinsulinemia in the blood. Because if it is high, independently of glucose, it causes atherosclerosis. Okay, it's one, I have worked in all my life in the lab, and one of the first experiences that I had, I just put some insulin in fat cells, okay, just to look at them. And I can tell you that after 24 hours, almost the curve flow up, because the insulin is such a potent lipogenic, that means proliferation of fat. So the first thing that happens, without even any hyperglycemia, is you start to build your atheroma. And this has been published in so many
that is
big
lipogenic
studies.
theory.
Yes,
Lipogenic theory of diabetes, yeah, agreed.
Many. Hafner from San Antonio, and I think the Framingham study showed that people without diabetes those who have higher insulin in their circulation are at higher risk for atherosclerosis. So we don't need the glucose. We don't need to arrive to hyperglycemia. We need to start much earlier to reduce the insulin level. The problem is that, first of all, we don't hear about it. Okay, there were some publication, but only those who are doing this research know about it. If you talk, even in Israel, that we are very developed in diabetes, if we talk to people to say, I have tried it, let's do, instead of doing so many, let's try to do in population at high risk. I know that there is many families that have high incidence of type 2 diabetes. Let's start with the adolescent. Just check insulin in the blood. If it is high, without even levels of blood glucose above 100, because for me a child has to have 70 or 80, not even to arrive to 100. And we should keep the child, keep the adolescent, keep the young person, keep the adult on much lower blood glucose, which is only secondary to what is happening in the body. So we have to start much earlier and find a way to test insulin in the blood cheaply. And this is what my patients know. I tell them, your insulin is high, then you are older in age. You are 10 years older than your age. If you keep your weight down, you test your insulin every year, and it is down, and he will make the effort because he understands that he will be younger having a much lower insulin level. Because the glucose is it fluctuates, it does nothing, it says nothing. It's very secondary to what happens. You eat, you higher your insulin, but insulin is really something that says that something is going on, something that is pathological going on with the secretion of insulin, and it is associated by many studies, we don't need anymore, with atherosclerosis, which is the first thing that we want to prevent.
So what do you suggest? Suppose I leave it to you.
Yeah, I do it.
I give you a patient population. You have to decide whether they are diabetic or not. What test you are going to recommend?
But we do it all the time. We take population. We have one diabetic person, whether it is type 1, type 2, we take all the families.
Well, madam, when we talk of, today, we mean literature-wise. What is the golden test? Gold
insulin,
standard?
yeah. I want the insulin of every...
No, but it's not a recommended procedure. What is the recommended procedure to know the diabetic status?
Well, if you want to do by ADA, you do the glucose.
Yes.
But I don't agree with that. That's what I mean.
No.
I mean it's too late, the glucose status.
Opinion variation is a different thing. The standard procedure to know whether someone is diabetic or not is very clear. It is only 2-hour post-glucose load, which has to comply with the standard limit, number one. Number two, you are correct. I think whatever you are willing to indicate is pre-diabetic status. In pre-diabetic status, there is a minimal glucose abnormality and hyperinsulinemia can be detected. So whatever she is describing to my mind pertains to pre-diabetic status. And this is very well discussed thing, it's nothing new. everybody knows, if glucose levels are normal or below the diabetic limits, and as she is rightly insisting that hyperinsulinemia should be focused, and if you check hyperinsulinemia, it will be there. I think they should be regarded pre-diabetic. So, when we talk of reversal, the reversal can be two-folded. You have reversed diabetes to pre-diabetic state, or you have reversed it to normal glycemic stage. That means NGT, right? So that too can be accepted. That is also reversal, might be partial. Agreed. So, do you have any views on reversal? No. No. Anybody else who would volunteer to have his opinion about reversal of diabetes? Lot of research is going on reversal. Tripathi, sorry, you are Pandeyji, na? Pathakji, yes. How would you reverse diabetes in your patients if given liberty?
Sir, I'm a periodontist, so there is no relation.
I see.
But your patient must be coming with diabetes also. Right?
Yes. No, dental checkup is a must nowadays as per ADA guidelines every year. Yes. So I would like to draw your attention to a very interesting research which is by Roy Taylor. The research is very simple and astonishing. It has shifted the paradigm from chronic progressive to curable condition, as we were discussing. Their concept is hypocaloric diet. If you restrict calories, then body will consume its own fat for the needs, and fat disposal will be there. Then by MRI studies he has shown that merely 1 gram depletion of fat in pancreas can reverse diabetes totally. This is the latest publication, I think it was somewhere October or November in Diabetes Care. This second study from him, his first study pertained only for 12 patients. Then he has shown that many patients were reversed, but more interestingly, with relation to weight, he showed that before the weight was reduced, the fasting was normal within 12 days. So nothing doing with weight as far as the fasting is concerned, but of course for complete reversal and for postprandial reversal, it took about 2 months. It took 2 months with hypocaloric diet that diabetes could be reversed. This is the most shocking, and this opens a new Pandora that diabetes should not be regarded chronic progressive disease. So this is one emerging area, because the topic on which we are discussing is emerging focus in diabetes research. So one focus we have already discussed. If somebody has not to make any more comment, then I will shift my discussion to any other focus.
I just want there is one thing that we did not mention here, and it's very important. It's the results of bariatric surgery. Okay, we all know that in 80% bariatric surgery, 70-80% completely reverse diabetes, even before weight loss. So this is something that should be taken into consideration.
Actually, whatever I am telling you is after effect of bariatric surgery. When in bariatric surgery, it was noticed that within few days fasting is normal and there is no substantial change in weight, then only the concept of diet came, because at that time and before few days, 3-4 days before bariatric surgery, patients are kept on semi-liquid and liquid diet, which is very low in calories. That is how the concept of hypocaloric diet could emerge. It is only out of bariatric surgery. She is very correct.
No, my concern is that it is chronic progressive disease. You can reverse it with that certain measure maneuvering, but after that, one is normoglycemic. What stands after that?
Yes. In this study by Roy Taylor, after giving hypocaloric diet for 15 days or 21 days, he allowed normal diet. And then he saw the effect lasted for 2 months. All those who reversed remained normal for 2 months. After that, the failure started. Some went on to pre-diabetes, some went on to florid diabetes, So the failure rate now, the question is how to sustain that period of reversibility. That's correct.
Yeah. So I'm telling you that because, we always go by quality of life. I presented yesterday's paper with the quality of life in diabetes patient. You cannot keep a person for entire life on hypocaloric diet, right?
But hypocaloric diet is nothing to do with quality of life. By a nice planning, you can enjoy quality of life as well as good diet.
It depends upon
It depends
culture.
upon the diet planning.
No, so it depends upon also culture to culture different because, this is a social disease.
Yeah.
Diabetes is not in isolation. Diabetes, like hypertension, is a social disease. You are in the society. You cannot isolate a patient and put
Given the choice, quality of life versus diabetes, what you will pick up?
I will live comfortably and die rather than one day I have to die. So I should not have complications, but I should live my life.
No, I wonder.
Yeah, you may differ.
I
with
wonder
that.
anybody would like to compromise with quality of life to some extent, and trying to get rid of diabetes will be the prime focus.
But you are not. Failure is coming. Hypocaloric diet will sustain for some time, but not for always.
This is the emerging focus. We have to see how to prolong. Even with bariatric surgery, the results are that after 6 to 8 years, about 70 to 80% patients fail. They come back. But of course, it is because of the failure of bariatric procedure. The patient adopt newer technique. They start taking many diets daily and they pick up weight also along with that. So since most of those are having bulimia also, the behavior treatment is not done very successfully. So most of the time these patients evolve their own method of taking high caloric diet by nibbling day long through smaller portions. So even despite bariatric surgery, they pick up weight and then they pick up the same amount of calories and start failing.
So
This hypocaloric diet is not forever. It is
not forever.
Only for 1 month or maybe 2 months.
That's what I told you. 15 to 21 days he gave only hypocaloric diet, then he sent back the patient to their own houses and allowed normal diet. Then he watched how long does the effect last, and the current study shows that the effect lasted only for 2 months.
See.
And now a lot of more research is going on as the topic is the emerging focus. The emerging focus is how to prolong this period to years. That is how the patient can remain drug-free and disease-free for pretty long.
yeah, so if that is sustained, then that is success. That's for sure.
But that will be substitution for bariatric surgery.
Yeah.
Suppose you get ways to strengthen, to stretch this period to 6 to 8 years, then nobody will resort to bariatric surgery, and that is what the effort is going on.
So that's why, coming to the topic of the emerging focus in diabetic research, so whatever the lost beta cells, how to get it back, how to regenerate, how to transplant, those type of focus should be there because, from 1920s onwards, we have insulin, we have oral hypoglycemic agents, we have different things, but, so far, as graph of diabetes is up and up and up, right? So those have not arrested the progression of the disease, right? So other modalities, other treatment should be focused on to get the beta cells back.
Well, I would like to draw your attention to another research by Roger Unger of Dallas, of course, Dallas Institute of Medical Sciences, the same city, in which he showed that beta cells have lesser role, alpha cells have bigger role. He had done experimental studies in which he destroyed all beta cells. Still the patient became diabetic only when there was hyperglucogonemia. If he suppressed glucogonemia despite no beta cells, diabetes was not there. This is an experimental study by Roger. But of course, not much work has been done in this field, but I can definitely indicate that the focus is now being shifted to alpha cells instead of beta cells, which are hypertrophied in type 2 diabetes as well as in type 1 diabetes. So this focus is also shifting. As we will have potent hypoglucogonemic drugs, that means those drugs which will reduce glucagon level, I think beta cell role will be minimized.
Another thing is
You use this,
and persistent. Yes. a persistent and prolonged hyperglycemia will cause a toxicity to the beta cells, right? So in that case, beta cell will not function well. But if you manage,
Yes.
when hyperglycemia is managed, so this toxicity state
Correct.
will be reversed.
That is glycemic,
So
glucose
beta-
toxicity.
Yeah. Then
The same way lipotoxicity.
Yeah,
If
then
you
beta
reduce
cell-
lipotoxicity and glucose toxicity, then
Yeah. Beta
the
cell will
little beta cells which are
start
there, they
working
start
again.
functioning better.
Yeah.
Yes.
They will increase in number and they will increase in mass. So
But
this
yesterday one of the paper was presented, de-differentiation. Beta cells get converted into alpha cells.
yeah.
And then start producing glucagon.
Glucagon.
Too much of proliferation of beta cells also lead to
Worsening of diabetes.
worsening of the beta
Diabetes.
cells, the toxicity you are mentioning, and that convert into alpha cells.
They have a potential.
It's very complex mechanism it is.
So I think 15 minutes are, getting very close. So we can.
Yeah.
Last but not the least.
No, it's never the least.
Whatever may be the research, whatever maybe you are doing is not our concern.
Yes,
As a patient, as a human being,
Yes.
the main concern, we want to live good, we want a good outcome. Unfortunately, so many things are being done globally for the prevention, for the cure, but we see that the prevalence of diabetes day by day increasing globally. So there must be some gap somewhere. What
What is the comment like?
What we are doing is not appropriately compatible with our target. I think we have to rethink, we have to reshuffle, we have to reset our target points.
Correct. We have to compromise with quality of life to
Yes.
some extent and adopt exercise regularly, leaving quality of life aside.
So the
Because 20 times more glucose is utilized during exercise, it's a very well established fact, right? So, he is very correct.
Yes.
The focus should be on exercise and daily exercise from the childhood,
Yes.
so that the incident diabetes could be reduced without any investment.
So I think at times many authorities, bodies, they should consult for rethinking whether we are on the right track for the target, whether we need to modify our target efforts for the future. Number one. Number two, very basic question. So many things as definition of diabetes, the hypocaloric diet, other components, insulin, glucose. Which one is the correct definition indicator?
We leave it to the
Actually, still it is very cloudy. Always I think, I feel it is cloudy. When really diabetes starts? What is the trigger point? What is the cutoff point for starting diabetes?
I know. 199 is the cutoff point and 200 is the diabetes.
It is
As of today, the picture is very clear. 199.99 is non-diabetic and 200 is diabetic. This is the cutoff point for PP, and as far as the fasting is concerned, 125.99 is non-diabetic, 26.9. Now you can say, how does it matter as far as the 0.01 is concerned, but the strategy is like that.
Sir, this,
And with
this
interesting comments, I wish to close this session. And
this is something like my boss has told it, so it is correct.
no,
And
it's not
something
a
like that.
No. You see, it is a very, very simple procedure. There are always good scientists and researchers. You will have to agree. I am fan of David Nathan. In most of the American Diabetic Association's statements and positionings, he is the chairman of the person. These are the true researchers on diabetes. They are working for 40, 50 years. And there is a big team which takes years to discuss and evolve any positional statement. So that's not that simple, and that is not that one way. It's always a multi-people effort, and we should not question that. Faults might be there because the human errors are always there. Yes,
we need to
last
rethink,
comment, please. Last comment.
We need to rethink because we are failing.
They
to
revise.
reduce the
From
prevalence.
time to time, these discussions. That is how the definitions are changing. The cut-off points are changing, not only on diabetes, on blood pressure and everything.
in all-
So
everywhere.
that is science. Science always reviews. Science always rethinks. So I think this is enough as far as discussion.